effective science communication that reaches across divides. I think we all know that as the COVID-19 pandemic reveals really some profound gaps and divisions in our society, we need to really learn this skill of bridging more than ever. And Alan will speak to the focus of our conversation today, the silent and growing epidemic of chronic pain. We'll then hear from two wonderful Rita Allen Foundation scholars, Ted Price and Alfonso Romero-Sandoval, about the promise and urgency of basic research to uncover solutions to chronic pain, with effective communication being a key to our progress. Chronic pain is a civic science problem. It's at the intersection of science and society, and we all know that solutions, as important as scientists are, will not just come from scientists alone, but from partnerships across basic science, policy, social science, media, and with diverse communities. So together, our goal is to shape new narratives in the story of chronic pain, drawing from people together in the need for new approaches, new voices, and leveraging the full range of our resources. The Civic Science Fellows Network is being co-created to build just this kind of collaborative learning and action. It's a new initiative with the intent to build a community of learning and practice to help us more effectively address issues at the intersection of science and civic life. In February, we launched an outstanding cohort of Civic Science Fellows and partners at the Gates Foundation in Seattle. And today, it's even more clear to all of us about the urgency of working together on emerging complex issues like chronic pain, which has many challenges, including issues of equity and access to treatment. We're seeing these, of course, mirrored and deepened by the COVID-19 crisis, and the pandemic will be very much part of our topic and conversation today. We've also approached launching the Fellows Program as a civic science lab, and we do so with intentional learning, humility, experiments, and sharing what we're learning. And we like to think about community and civic life, which is so upended now, that we seek with great urgency to prioritize those who are most vulnerable and marginalized. We also know that some of our greatest answers for relieving suffering can be found in science, and we have an urgent need to share knowledge and to more effectively innovate, collaborate, and coordinate our responses to build hope for the future. In just a moment, I'll ask our moderators to open the conversation with our speakers. And then we'll conclude with a request to hear your questions and thoughts on how we can leverage our strengths and support shared work in response to the silent and growing epidemic. But co-moderating today's webinar, we extend a very warm welcome to the first Alda Civic Science Fellow in Chronic Pain, Greg Carbonetti, and Executive Director of the Alan Alda Center for Communicating Science, celebrating its 10th anniversary, Laura Lindenfeld, who wears many hats, has many roles, and certainly has many talents. And so to begin this conversation, Laura and Greg will share a little bit about themselves and the deeply important work of the Alda Center. Laura, will you please start us off?
Sure. Hello, welcome, and thank you for joining us. I scanned through the names and see many familiar names and new ones, so it's nice to have you on this call. For many of you who are aware of what the Alda Center does, and for those who aren't, we train scientists to communicate, and we do that in such a way that builds empathy, connection, and trust. And when I think about complex societal problems like chronic pain and the science of chronic pain, what better way to help people connect than to think of communication as building trust and community and a broader sense of belonging around which we can solve such pressing problems like the ones that present themselves to us through chronic pain. So this is a really important topic area that often gets swept to the side and not talked about. And indeed, and you'll hear Greg talk in a little while, we don't have a coherent narrative around what chronic pain is, what the experience of it is like, and how to treat it. And that undermines the very people who struggle with chronic pain. Let me just present a few of the data points around chronic pain that are so compelling. Chronic pain impacts more than 100 million Americans. It's among the most widespread, serious chronic health conditions that confront our society today. The overall cost to the US for treating chronic pain and not always treating it well is estimated to be between $560 and $635 billion per year. The suicide rate for chronic pain sufferers is more than double the national average. It makes sense, but it's stunning when you let that number sink in. There are equally significant issues, there are significant equity issues for chronic pain treatment. Women are treated less aggressively than men, and Black patients are half as likely to receive medications as their white counterparts. Staggering, even if they have the same exact symptoms. The story moves quickly to treatment of addiction or end-of-life pain rather than new options for treatment. And all of this, whether it's the experience of chronic pain and naming it and calling it and treating it fairly, or the science of chronic pain that enables us to do better bench to bedside treatment, enable people really to flourish, deserves more communication. And it deserves communication that's grounded in the actual situations in which people live, that takes those situations seriously and helps us build more scientific enterprise and stronger collaboration so that we can really help treat people and resolve the terrible issues that they face. So that's why we are hosting Greg Carbonetti. We're so thrilled to have you as our, it's the Civic Science Fellow in Chronic Pain. I hope we don't put you in chronic pain, but rather that you are helping us manage the narrative about chronic pain. But we're so thrilled to have you on board. You're really helping us to think about how this cross-sectoral problem that needs to engage people from the scientific community, the physician treatment community, journalism, social scientists, and of course, those of us working specifically in science communication. The Alda Center is a great place for us to have you, and I was so thrilled to welcome you on board. So I'm going to let you talk a little more about the work you're doing. Thanks.
Thank you so much, Laura, for the nice introduction. And thank you to Elizabeth and the Rita Allen Foundation and all the panelists that are going to join us today. I'm really excited to be a part of it. So quickly about myself, I'm Greg Carbonetti. I'm the Rita Allen Civic Science Fellow in Chronic Pain. And no, you haven't created chronic pain for me just yet. I received my degree in molecular and cellular biology from Stony Brook University just a few months ago. And while I was there, I did my work in the laboratory of Dr. Martin Kachowa. And our main focus was the design and synthesis of small molecule inhibitors or drugs as a therapeutic alternative to opioids for the treatment of chronic pain. And it was during my time at Stony Brook University that I had the tremendous opportunity to take classes at the Alda Center and learn as much as I could about the science of science communication and how to design messages with audiences in mind. And it was during this time that I realized that there were other capacities and very strong avenues through which I can continue to help tackling this chronic pain problem outside of Ben's research. And I found myself being drawn to this increasingly growing field known as civic science. And the rest, as they say, is history. So as has already been really beautifully framed by both Laura and Elizabeth, there are a myriad of wicked problems that are associated with chronic pain, be it the social equity issues, the economic burden created by chronic pain, the physical consequences and comorbidities associated with chronic pain, as well as the opioid epidemic, which certainly can't be understated. And these problems won't exclusively have scientific answers. And that's where civic science comes in. These problems are going to require action and effective communication from all public stakeholders, including the scientific community. And this process of civic science by which we have societal discussions based upon information science provides us that will hopefully result in better evidence-based decision-making and policy-making. These are going to be vital to resolving these issues. But as Laura had touched upon, before we can truly engage with civic science to help solve these issues, we need to shift the public discourse surrounding chronic pain in the United States away from one of apathy on behalf of the patients that feel as though they're not receiving adequate treatments, as well as the stigmatization of those people that are seeking therapies that work for them. But as I had alluded to, the opioid epidemic has unfortunately cast a pall upon. So we need to move this public discourse away from apathy and stigma towards one of awareness, understanding, and even optimism that science can bring us with new discoveries. And this shift in public engagement, I'm hoping will encourage a reassessment of our institutional and organizational structures, and most importantly, amplify both chronic pain research and chronic pain research funding. This recommitment to chronic pain research will obviously and hopefully lead to new and exciting therapeutic alternatives for the treatment of chronic pain. But more importantly, as a society, it's going to provide us the opportunity to make better value and evidence-based decisions with how we treat chronic pain in the United States. So my work as a civic science fellow dealing with this problem of chronic pain is going to start right there. How can we help and start shifting rather this public discourse surrounding chronic pain? And I plan to do so using the main tenets of the Alda Center, which are empathetic listening, clear and vivid communication, as well as utilizing the science of science communication. How can we design messages that are going to be impactful and resonate with the audience that they're designed for? And I've been in contact with researchers and some clinicians, and soon to hopefully be in contact with many chronic pain patients to help elucidate their narratives, listen to their stories, find what's really going to resonate with the community so that we can remobilize and build something better than it currently exists. So I'd very much like to continue talking about that, but I can go on for a few hours. So at this point, I'm going to send it back to Laura, who's going to introduce our first panelist, who certainly does not need a very large introduction. And he's acutely familiar with a lot of the things taught at the Alda Center because it bears his name. So without further ado, I'll allow Laura to continue his introduction. And thank you so much for being with us today.
You stole my line, Greg. How do you introduce Alan Alda? Well, let me just say what a joy it is to have you here with us today, Alan. Aside from being an actor, writer, creative genius extraordinaire, your founding of the Alan Alda Center really helped move the conversation about the importance of communication to and in science, light years beyond where it was. I'm not going to go into too much detail about who you are because really what people want to do is hear you talk. And I'd love to start you off with a question of a situation in which you experienced dire pain that helped lead to the founding of the center. Can I hand the torch to you now to talk, Alan? You got to unmute, Bubala.
I'm not used to muting, so
there you
I
go.
seldom mute
Right.
myself. So
Thanks, Alan.
I'm unaccustomed as I am to muting. So you're right. There was one night in my life that led to crystallizing what I had been learning all before that night, all my life as an actor, that could be useful to other people. Because as an actor, you have to relate. You have to pick up cues from the other person, and that changes the way you respond when the other person talks to you or does something to get your attention. It all has to do with picking up cues, not verbal cues, not line cues, but picking up cues from the face consciousness. And that's how you get a good performance out of yourself. And the other actor picks up your cues, and it builds in a dynamic way until you have real life taking place instead of just play acting. And I've been doing that all my life. And when I did the science show, Scientific American Frontiers, I interviewed hundreds and hundreds of scientists, and I found out that they were really conversations. They weren't standard interviews. I was trying to understand what they had to tell me. And I was reading their face. I would shake them if I didn't understand it. And I'd say, explain it again, tell me in a different way. So I was getting the real story out of the people. I was getting their real humanity out of them. They couldn't just give me a lecture. They had to explain to me in ways I could understand what their work was all about. And that was the beginning of the Alda Center. And it really crystallized one night when we were in Chile. And I was interviewing astronomers up on top of a mountain in their observatory. And I was waiting for them to light the room where we were going to do the interview. And I felt this kind of cramp in my gut. And then it wasn't a cramp anymore. It was the worst pain I had ever felt in my life. I thought it was appendicitis. Turns out it wasn't. They took me down a bumpy mountain road. I'm screaming with pain. I didn't have long-lasting pain, but I would have been home because it was so bad. It turns out it wasn't appendicitis. It was part of my intestine had been crimped off, and I had lost about a yard of my intestine. Not that lost, I'd lost the blood supply to the yard. The moment that changed things for me was when the surgeon in this little dimly lit hospital in La Serena, Chile, said to me, he leaned down into my face first, and he looked me in the eye, and he said, here's what's happened. Some of your intestine has gone bad, and we have to cut out the bad part and sew the two good ends together. And I sort of knew what he was talking about because I'd done that operation on MASH. But what astonished me was how direct this communication was. He was looking at my face to see if I understood him. He told me in plain words. What he said to me is officially called an end-to-end anastomosis. If he had told me that's what he was going to do, I might have understood because I did that operation on MASH, but any other person wouldn't have understood. Instead, he told me in terms that were plain English, but just as accurate. He didn't dumb it down for me. He told me in plain words what it was. And that did crystallize things for me. And for a couple of years, whenever I was at a university, I'd ask, couldn't we teach scientists to communicate really winning any traction? Nobody wanted to buy into it. Is that I got the effect I got with the scientists when I was urging them to explain things to me in ways I could understand. What I got from them was due to what I had learned, not only as an actor, but an improviser. There are very specific rules to improvising, and there's an experience that you can go through to learn to improvise and make a connection with another person that's deeper than you ordinarily have with anybody. So I was going to be at the University of Southern California, and I asked if they'd bring in 20 engineering students, and I asked them to talk about their work for a minute or two, and then we improvised for 3 hours. Very particular exercises. It's not, improvising is not making things up, and it's not joke making. It's learning to connect. And at the end of the 3 hours, I asked them to talk about their work again, and everybody in the room was astonished that it was coming out in a much clearer way, including me. I didn't know if it was going to work, and it did. And a year or two later, Stony Brook said they were interested in trying it, and I trained trainers to train improv. And a few years later, Laura Lindenfeld came in, and the thing took off like mad. And as a result, we've trained over 15,000 people in every state in the country and 8 other countries around the world. And we see the effect it has on them. That's startling. And we've also trained physicians and nurses, and we see the relationship that they have with their patients is much more powerful because it involves listening and paying attention, just like the doctor Nelson Zepeda in Chile. When he was looking at me to make sure I understood him, that connection helped me understand him. And he was ready to change what he had to say if he saw something flicker across my face that looked like confusion. So I feel so lucky that Stony Brook picked up on it, that this amazing team at Stony Brook has built on what I started. And we've turned ourselves now, because of the coronavirus, we've turned ourselves into an online workshop school, and we're able to do the same things we were doing all around the world face-to-face now online, because we've translated this way of connecting and the way of teaching to connect to this kind of experience. So that's how we got it started. I hope that was a clear enough picture. What do you think? Did I leave anything out, Laura?
That was damn good.
And And thank you so much for your words, Alan. It's a really illuminating story. And I think your experience with pain in Chile really speaks to the broader, one of the broader issues related to chronic pain. And that is just, how we communicate about pain, how we understand pains as cultures, but that empathetic listening and that engagement between doctor and patient really lies at the core of some of the issues related to chronic pain. Thank you once again, and we look forward to hearing from you in a little bit again. But for right now, I'd like to take the opportunity to introduce our next panelist, and that's Dr. Alfonso Romero-Sandoval. He's an associate professor in the Department of Anesthesiology at the Wake Forest School of Medicine. He was the 2011 recipient of the Rita Allen Pain Award, as he's one of their scholars. And he's gonna take some time today to tell us a bit about his work and how these issues regarding chronic pain really truly meet at this intersection of science and society. So if you wouldn't mind sharing a few things with us, Alfonso, we're looking forward to it.
Thank you. Thank you, Greg, and Elizabeth and Laura and everybody for inviting me to be here. It's an honor to be with great panelists as all of you guys. So my lab has been focused in multiple fronts, including the interaction mostly of the immune system with the neuronal circuitry that is in charge of the experience that we call pain. So basically how immune cells interact with all the wires that we have that make us feel what we call pain. So this is not a new concept anymore, but this area of research has brought fascinating alternatives to understand how pain is generated and amplified by actions of immune cells. That means cells that are not necessarily the nerves that transmit electrical signals to the brain. So we are not the only group investigating ways to understand the immune system and its reactions to environmental changes or anything that is surrounding us as human beings to promote or to enhance pain. But my team has been trying to introduce new cues to specific immune cells, trying to re-educate these immune cells to make them adopt functions to promote restoration, to bring back the normal sensing of pain or to reduce pain. So in other words, we are trying to educate the immune system to promote resolution and to promote the recovery of functionality or to regain the normal functions in patients, which we have been interpreting basically as the resolution of pain. However, based on my clinical experience and on what patients refer about their experience with pain and with its treatment, we're trying to redirect our understanding of pain and its manifestations, how pain manifests. I think we believe that we are evolving by listening to stories as the stories that we have just heard today. So we are realizing that for a large portion of patients, the restoration of functionality is what they use as a measure to determine how good or bad their pain is evolving. Things like as simple as grabbing a spoon to eat, reaching to a cabinet to get a utensil, or standing up without avoiding the pressure on their knees, walking to visit their daughters 2 blocks away or 2 houses away, or feeling warm water as warm water instead of burning hot water, etc. So those activities are simple, but we are trying now to incorporate those into our research. We are trying to put those metrics in our animal models, in our animal behaviors, since it seems that simple quantification to rate pain intensity does not reflect the real dimension or does not reflect all the dimensions of the experience that what we call pain. So why chronic pain is so devastating? So perhaps chronic pain is devastating because we scientists and clinicians have not been able to figure out completely an experience that is very complex, because it is invisible, it is abstract, and it is subjective. So any similarities with the current pandemic are pure coincidental. But as the pandemic, pain is also erratic and very fluid. So this inconsistent pattern makes it extremely difficult to fully understand and to fully tackle and to fully mimic it in our animal models as basic scientists. So therefore, patients do not have solutions, and they are the ones dealing with the consequences. So I am adding an additional level of understanding to chronic pain with a personal experience with my mom. You know, she's a chronic pain patient. So I have seen that chronic pain patients often feel unheard. They feel that doctors do not understand them. They feel that they are basically isolated, confined inside themselves, and dealing with the inability to do simple things that happen to give sense or purpose to their life. And those simple things are actually devastating for them. So how I believe that civic science can make us better understand this problem, how make us tackle pain at a different dimension. So I think that the term civic, it's just perfect to understand the science of communication in the context of chronic pain, as it is, of course, for other major challenges like COVID-19 or climate change, you know, gene therapies, nuclear energy, robotics, etc. Right? And it is because civility, it's defined since ancient times as the training in humanities, and in later times as a conduct based on courtesy and politeness. So maybe using a polite, cordial, and humane dialogue with patients is the most effective way to reach the next level in pain research. And we're trying to understand this and bringing it to our lab, which is very challenging, trying to collaborate with people who does complex behaviors and other kind of things to incorporate it in our research.
Thank you so much, Alfonso, for sharing with us.
Question.
And also, it's brilliant the way that you
Greg, could I
framed
ask
it.
Alfonso a question?
Oh, by all means, sure, Alan.
Thank you. It was interesting to me when you said that the pain patients don't feel heard by the physicians. And I'm wondering if they get enough training in exploring the question of pain itself so that they take reports of symptoms of pain seriously, as even though they might have a mysterious etiology, that there's something there. Because very often if somebody just says, oi, oi, oi all the time, they can be annoying to other people unless they recognize.
Alfonso, we may have some technical difficulties with Alan. Did you think that you received enough of his
I think so.
question to maybe respond?
Yes, I think I captured the most of the words and the sense. I think that is a great point. I remember when I did the med school, I never ever received a particular course regarding pain. I didn't even look at chronic pain as a particular syndrome or disease, because back in the days it was not considered a syndrome. And I think now schools of medicine and pharmacy and nurse are incorporating these concepts, but I don't think that is sufficient. And I don't think that current doctors are well trained to talk openly and about this very complex situation. So, and again, it is very difficult for someone to understand the whole dimension of pain, because we try to compare with things that we know. And for example, with diabetes, we know that if your sugar is higher than such amount, you are diabetic. If hypertension, if you take the blood pressure, you see numbers and you see that you're hypertensive. So we don't have that measure for pain. And on the other hand, different cultures bring different concepts in the minds of educated people as doctors, and also in the minds of patients that may not be necessarily well educated. In rural areas, for example, pain is a very different concept. So when I did my social service in Guatemala after med school, pain was totally different to what we actually sort of learn in a hospital. And therefore, a doctor may have different perspectives on pain. But certainly, I believe that educating doctors to ask the particular questions and to give them the tools to understand what are the dimensions of pain and the pain experience, it would definitely help to shape the conversation in a more meaningful way.
Thank you so much, Alfonso, and in particular, thank you, Alan, for that question. I think it does a great job really displaying just the magnitude of the chronic pain issue. And I'd certainly recommend to anybody who's viewing today to take Alan's cue, and please feel free to ask some questions, either using the Q&A or the chat feature, and we'll try to get to as many as we can. But in the interest of time, what I'd like to do now is introduce our next panelist, who is Dr. Ted Price. And for those that may be unfamiliar, Dr. Price is the professor as well as head of the Department of Cognition and Neuroscience at the University of Texas at Dallas. He was the 2009 recipient of the Rita Allen Award in Pain Scholarship, which I believe was its inaugural class. So Dr. Price has certainly been in the field for quite some time. He serves on the editorial boards for journals such as Pain and the Journal of Neuroscience, and especially want to point out that he chairs the editorial board for the Pain Research Forum, and they do tremendous work there. So without further ado, Dr. Price is going to talk to us today about the work that he's doing and his thoughts on expanding this landscape of chronic pain research. So if you'd like to share some thoughts, Ted, we'd love to hear from you.
Yeah, thanks, Greg. I'm really happy to be here. It's an honor to be able to do this. So thank you, Elizabeth, for organizing this. So my background is in neuroscience and pharmacology. I did a PhD in pharmacology, thinking I was going to work on mechanisms of depression, and did a rotation in a pain lab, and fell in love with the idea of trying to better understand pain. Later on in my life, I actually became a pain patient, and thankfully I've mostly recovered from that, but that certainly changed the way that I think about the research that we do. Our lab is really interested in trying to understand neuropathic pain, and our primary goal is to try to develop better therapeutics to help patients that have neuropathic pain. So neuropathic pain is a leading cause of disability. It's the most common type of chronic pain that people have when they have what we call high impact chronic pain, and the drugs that we have available to treat neuropathic pain really don't work at all. So there's a great need to try to improve the situation. It may be possible that there can be non-pharmacological therapeutics that could be used, but my area of expertise is pharmacology and neuroscience. So that's where I try to focus our lab's efforts. So, we have taken the approach that we can do a lot to try to find novel mechanisms. And we also want to try to push those things towards the clinic. So we've been active in being entrepreneurial, but that really has nothing to do with me having any major business interests. It's just the way that you have to go about things within the system that we have to try to move your own ideas and the therapeutics that you develop around them towards the clinic. So that's kind of a vehicle for us to try to do that. I will just close up by saying that I think that the question that Alan asked and that Alfonso so beautifully answered about education is really critical. That there just isn't enough education on pain happening in medical schools. I would argue that there's not enough education on pain happening anywhere, and that we really need more of this. Pain is something that almost all of us are going to experience at some time in our life. And for many of us, it will turn out to be chronic. So it will last for 3 months or more, which is how we currently define it. But for a lot of people, it'll be something that they're going to live with for most of the rest of their life. And in those kinds of situations, especially where we don't have the therapeutics that I think everybody in the field hopes that we can eventually have, knowledge is really power for people. So having chronic pain or having really intense pain that lasts for a fairly long period of time can feel like your body is betraying you. And understanding a little bit better what's happening, and it can be explained, it is complex, but it can be explained in relatively simple terms, can really help people to deal with what can be a really awful and negatively life-altering experience. So I think that's a really important thing for us to recognize, and it's a great goal for us to work on while we're trying to develop better ways to treat pain.
Thank you so much, Ted. Really enlightening stuff. And again, another dimension of the issues that arise when we start discussing the myriad of problems associated with chronic pain. At this point, since we've had an opportunity to hear from the panelists, we're going to segue into our question and answer segment. And we actually have had a few questions and we're excited to get to them. I believe that Laura is actually going to field the first one for Ted. If Laura, would you mind taking it away for now?
Not at all. Alan, I have a question for you. Are you still on there? Is he on?
He comes and goes.
He comes and goes. Okay, so Ted, I'll ask you, the pain field has long been underfunded relative to other areas of disease and health at both the federal level and from private sources. Why is that? And what is the impact of that lack of funding?
That's a great question. I think that there's very strong evidence that that's true, that it has been underfunded. So I'm best familiar with the NIH numbers. Chronic pain will affect about 30% of the population. The amount of funding that has been dedicated to this, you can argue, has been somewhere between 1% and 3%, even in the most optimistic of NIH funding, even in the most optimistic numbers. That probably is not enough to deal with the magnitude of the clinical problem. It also creates a huge financial burden because of medical care costs, lost productivity, etc., disability. There has definitely been, in my view, and I think most people in the field's view, underfunding. I think most people at NIH even admit that this has been underfunded. Why we haven't been able to deal with this is a tough one to answer. I don't think that I have an answer. Part of it you can probably draw back to there being somewhat of a stigma against pain and the opioid related problems that we've had in the last 30 years or so in the United States. I think some of it you can draw back to education, where people view pain largely as being a symptom. And I think we've learned in the last several decades of basic neuroscience research that pain often starts as a symptom, but it becomes a disease in and of itself. The best example of that is neuropathic pain, which is caused by a lesion to the nervous system. And the pain in that case really is a disease in and of itself. So I have some hope that that this is becoming better now and that there's more funding available, but it still, I don't think, equates with the magnitude of the medical problem.
Thank you, Ted. I see we continue to have questions come in, and we're going to try to get to them as best we can. And the first question that we received was actually from Benedict, and I'll read quickly, and perhaps Laura can respond on behalf of the Alda Center. And he had mentioned that he's a pain physician, and a major challenge that he has is communicating with patients, not because of their communication barrier, but just the restriction of time, that there's so many patients to see that they don't get an opportunity to fully engage with them. So Laura, is this an area that the Alda Center is going to address, or are there ways that we might think about tackling such a problem?
Yeah, and Benedict, I'm happy to follow up with you after this if you want to drop me a note. So this is a problem that extends beyond the pain community, the way that the medical system limits the time that patients and physicians have with each other. We've all experienced it, whether on the patient side or the physician side. I'm not a physician, and neither is Alan. He just plays one on TV. But what we're doing in the center is we've really explored the literature around team resilience and how the entire medical team, from the person at the front desk to the respiratory therapist to the nurse, how we can build better resilience among the team in support of the patient, so that if the doctor's time really is limited, there's a continuity of care and a commitment to working together. I realize that doesn't overcome the hurdle of having limited time, which is endemic, unfortunately, to our system, but it is an area that we've concentrated on in the Alda Center. So again, happy to follow up with anyone who wants to learn more about that.
Thank
Greg,
you, Laura.
should I ask a question while I'm at it?
Sure.
How about for Alfonso and Ted? I'll throw this at the two of you. Pain impacts different populations differently. And groups have access to treatments at different rates, depending on where you are, who you are, what kind of resources you have. What are some of the equity issues in the diagnosis and treatment of pain as you see them? And what do you see as some potential solutions to address these? And how might communication, I'm going to make this a really long question since you both get to field it, how might communication matter in that context?
Alfonso, since you have more clinical experience than me, you want to start on that one, and then I'll chime in.
Yeah, happy to do it. I believe that the larger issue of underserved populations, minorities, etc., is universal. So they certainly receive less attention for pretty much everything, right? And I'm talking about my personal experience in Guatemala as a physician. So people in rural areas, they have less access to healthcare, less access to education, less access to food, to potable water, to pretty much everything. So they start from very behind compared to the general population or compared to the average population. So that is a given. They will receive less of pretty much everything that is available. So that is a bad starting point. The second point is that the healthcare system does not see chronic pain or pain itself as one of the priorities. So then these patients are leave way, way behind. So how do we solve this? So I think it's a larger problem. It is not particularly for chronic pain. It's a larger problem for these inequalities. We have seen right now with the COVID-19, right? The Black population and the brown population are the most affected in COVID-19. And this is extremely sad and embarrassing. It's extremely embarrassing. When I talk to my friends from Europe, I cannot defend our health system. I cannot be proud of, I am part of the healthcare system as a scientist, and I am ashamed for that. You know, in Europe, the death of the COVID-19 has been determined by the age of patients, because there is more equality over there, right? And here, it is determined by if you are Black or brown. It's not only age, and that is a shame. It's very sad. And pain is pretty similar as the data that you show, Laura, before. So how do we solve this? So I believe that the financial or economic aspects of inequality in pain diagnosis and management should resonate louder in our ultra-capitalistic society as the one in the United States. I have been educated mostly as a physician and as a PhD in a social academic environment. And it is beyond my comprehension. How is that possible? That our capitalistic system does not realize that it is way more expensive to have disproportionate healthcare system that leave behind and apart large populations of our society. So maybe talking to policymakers and legislators about the monetary cost of not diagnosing or not providing management alternatives to underserved minorities would be a better way to make them understand that all humans deserve pain treatment as a fundamental human right, but also this will be more costly effective for the state and for the whole economy. So maybe that is one of the potential larger solutions, a disruption of the system in such a way that we could probably tackle the minority inequality in a more broader point of view. Sorry if I talk about something else, but that's how I see the problem.
I think that you stated it very well. I mean, we have I totally agree. We have a huge problem with racism, and we have to face this as a society. I mean, it's embarrassing as a society that we're not number one, and it's completely unacceptable. That's number one. number two is it's embarrassing. There's all kinds of data out there from many different outstanding researchers in the field about how minorities get inadequate pain treatment. You know, sickle cell pain, which is a huge problem, primarily affects African Americans and some Latin American populations, and we've done very little in terms of research on that until like just the last couple of years. And it's remarkable to me that more work hasn't been done in that area, and that we don't do more to try to help people that have these major pain problems. So there are all kinds of other issues related to the healthcare system, which I think Alfonso did a nice job of addressing, but it's definitely a huge issue, and it's totally unjust.
Thank you, Ted and Alfonso. I actually have a question here from the chat that I think I'm going to attempt to tackle, and then I have another question I'd like to throw Alfonso's way. But the question that we had received was, when it comes to talking about chronic pain with the public, what's something that science communicators and journalists can do to help structure the narrative surrounding chronic pain right now? And as I had mentioned on the outset, I think that part of my goals here are to find what those narratives are, what those impactful stories are that are going to resonate with society. But it's a great question. What are things that we can do right now? And I've got a lot of ideas, but the one that sticks out to me at the moment is a theme that I think you might have heard arise through some of the statements made by Alfonso and Ted, and that is the heterogeneous nature of chronic pain. We all have an intimate knowledge and understanding of what pain is, but it's not the same for chronic pain. I think an analogy could be made towards cancer, in that not every cancer is the same. Lung cancer is different from stomach cancer, from colorectal cancer, so on and so forth. And you see the same exact thing with chronic pain. There's neuropathies, there's pain that arises from trauma, so on and so forth. And they each utilize different molecular pathways, and they have different ideations and ideologies. So I think one way that we can start thinking about chronic pain right now as communicators and journalists is just that it doesn't fall neatly under one umbrella, and that there's many different forms and flavors, if you will. And certainly Alfonso and Ted and any of our other panelists, if you'd like to jump in as well, I don't want to make the blanket statement on that, but in the interest of our conversation today, I had another question for Alfonso, and it relates to the current pandemic that's happening. So the issue, or one of the issues, the many issues as we've been outlining today as it relates to chronic pain, is that it often gets lost in the dialogue about other diseases. In particular for chronic pain, the opioid addiction crisis. Not that it's a small problem by any means, but more often we're thinking about chronic pain through the lens of the opioid crisis as opposed to chronic pain itself. So with that framing in mind, now that COVID-19 has been ravaging the country for some months, what are ways that we might address how COVID-19 is going to be taking away, and rightly so, some of the discussion as relates to chronic pain, and what are the role of stories that we'll receive from patients, and how we can utilize the COVID-19 pandemic to really amplify the problems of the pandemic, but also keeping chronic patients in mind.
Yeah, so as I say, it's a very broad problem. I believe that that chronic pain is being hidden by any particular crisis, and if we think about it, the world is constantly in crisis, right? So if it is not COVID-19, it's something else in terms of health issues. So chronic pain is constantly being hidden by crisis after crisis, and we don't realize that chronic pain is a critical issue itself. So I believe that there are multiple factors that makes pain invisible, right? And therefore, it is easy to set it aside in times of other crises. So for example, a chronic pain patient will not occupy a bed in a hospital, as a patient, as opposed to a patient with acute pain because of appendicitis, right, as Alan, or pancreatitis, or as a patient with diabetes and a complicated foot ulcer, or a hypertensive patient with a heart failure, right? These patients occupy a bed. And bed occupancy is the indicator for hospital costs. And hospitals account for about 30% of the healthcare spending in the US, approximately. But in other countries, this percent is much larger. It's 50 or 80% of the total healthcare cost. So chronic pain patient costs are not reflected in the most visible line items in our health system budgets. So chronic pain patients were more visible before this pandemic as outpatient clinics though, right? But they were easily dispatched by prescribing large amounts of opioids, right? And we know now how that ended. So the mechanism by which the health system works pushes chronic pain patients to a darker side in which they become even more invisible. So there is a misconception of the whole chronic pain thing that chronic pain does not kill anyone. And maybe that is why, we put them apart, because COVID-19 can kill you. A heart attack can kill you. A stroke can kill you, but chronic pain won't. So let's deal with the most imminent problem here. But I myself have used that concept that chronic pain doesn't kill anyone. But in reality, if there are more suicides in chronic pain patients than in the general population, we should change that discourse. In light of that evidence, it seems that chronic pain could be lethal, and perhaps those fatalities are avoidable if we make patients visible and are managed in a more humane way. So I'm afraid that the physical isolation is worsening the overall well-being of chronic pain patients for multiple reasons. So right now, because of the COVID-19, patients are being isolated, they're by themselves, they don't have access to any other things. And the lack of things range from the reduction in physical activity to the increase of time available to ruminate about their pain condition. So it will not be surprised that when we adapt to the new normal, we will have higher rates of chronic pain and its complications, such as depression, suicidal ideation, and potentially even suicides. So these obvious issues should make us prepare to prevent or treat all these devastating collateral consequences of the pandemic, because it will be actually very evident, I believe, in chronic pain patients. So bringing awareness on our chronic pain population during the pandemic should be part of our mission and narrative, I believe.
Thank you, Alfonso. We actually have a couple of questions that have seemed to latched onto a similar theme. So I'm actually going to throw this question to Ted. And the one that I'm alluding to is, as we've been discussing, there's this breakdown in communication along generational, ethnic, very different ways in which we all understand pain and communicate that to our doctors, which is another way of saying, Ted, is there a way that we can create a new language, or are there ways that science might be able to step in and help this communication between doctors and patients towards a more mutual understanding of their pain conditions as they present?
Well, pain is a very personal experience. I think if you have some basic understanding of the neurobiology of pain, it helps you to understand why that's probably true. So if you'll just indulge me on a little bit of science for a minute, I mean, our sensory systems, and pain is not really a sensory system, but it's part of the somatosensory system. They're wired up in very specific ways, so like you see through your eyes, obviously, and then it goes back to your brain to the visual cortex, and then it comes out from your visual cortex, and there's different areas of your visual cortex that are involved in different things. Same for auditory cortex, same for somatosensory, for light touch and proprioception and all that. The pain system comes up through the spinal cord like the light touch system does. But then it does something very strange. It goes into these brainstem centers, and then it goes all over your brain. It goes to the limbic centers and the amygdala, which are involved in fear and emotions. It goes to your prefrontal cortex that's involved in making decisions and cognition. And it has this huge impact on basically all of your most basic functions. And the reason for that is, I think, fairly clear. Your pain system is perhaps your most important alert system. If something is causing you acute pain, that is an emergency that you have to pay attention to, because if you do not pay attention to it, there's a good chance it's going to kill you. So, Alan's story is a great example of that. If he didn't go get medical treatment for what was happening to him, he probably never would have left Chile. Right. So now the issue is that when that persists over a long period of time, that alarm system being on all the time, sending the signal to your brain, has a huge impact on the way that your brain works. And my view is that, that intersects with all of the other experiences in your life and creates this very personal experience of how pain affects you. And, I think people that have chronic pain problems really want to have some understanding of why this is happening to them, because again, it is your body betraying you. And I had this problem with a spinal cord injury. I'm not going to go into the details because it really, like, emotionally is too painful for me to talk about, and it was also the most painful experience that I've ever had in my life. But I remember thinking at some point, and it was weeks that I had this awful pain, that I can't live like this. I literally can't live like this. That there's nothing that, if nothing is going to make this go away, my life as I know it is over, and I'll be a completely different person. And that was both horrifying and created this sense of desperation that I had never imagined was really even possible, which is why I don't like to talk about it. But I think that we all kind of need to understand this, and again, just some really basic neuroscience that I think almost everybody in the population can understand is very illuminating there. So, I would love to say that we're going to have better therapeutics that will stop people from getting into this situation to begin with. But, we've been working on that for a long time, and we haven't had any major breakthroughs. And I'd love to say, yes, it's going to happen in Alfonso and I's lifetime, but it may not. But then again, just being successful in helping understanding and spreading education on this most basic thing could have a gigantic impact.
Very well put, Ted, and thank you so much. We're running a bit short on time, so I'm going to throw over to Elizabeth to take us home. But once again, I wanted to take a moment and just appreciate everybody for participating in the webinar today, especially our panelists. And without further ado, I'll let you take us home, Elizabeth. Thank you.
Well, thank you, Greg, very, very much. Again, we're extremely excited that you are the first Civic Science Fellow in chronic pain to, again, bring together journalists and social scientists and people across sectors to really honor the work of the scientists in the lab trying to look for longer-term solutions, and to really appreciate, thank you, Laura, particularly for hosting the fellows, saying yes to this pioneering work, for being a pioneer yourself. And certainly I know that Alan, who was experiencing a lot of internet problems, was extremely sorry that he had to drop off, but he was excited to be part of this and caring deeply about this topic too. The great good news is that as the Alda Center celebrates their 10th anniversary, Laura will be having an interview with Alan this Friday, and so we'll be sending out information to all of you to hear more about that. To both Ted and Alfonso, you are two of our most valued and both scholars in pain and scholars. We're deeply proud to consider you part of our community and part of this larger civic science community with fellows and funders and host partners and others who are going to help us understand new approaches, evidence-based approaches to addressing complex issues like chronic pain and the current pandemic we're in. We will be following up with a recording of this, so you can share this with your colleagues. We'll also be answering some of the questions that did not get answered today. We'll ask our panelists and speakers to speak to those, and we'll look forward to seeing you all again at another webinar and joining this conversation as we learn and connect to practice and think about the better outcomes that we all aspire for. So thank you all, and it was wonderful being with you.
Thank you.
Thank you all.